Thank you for coming to the Pathology Grand Rounds this Wednesday. I'm MKatus, one of the 4 surgical... Louder? Okay. I can hear myself, so I think all of you can hear me. Okay. I'm MKatus, one of the 4 surgical pathology fellows here at the University of Minnesota, and today I'm going to talk about Sellar and Parasellar tumors here, the experience at the medical center. So, like every presentation, these are the objectives I supplied earlier with the disclosure of which I have none. I have no financial or other relationships with pharmacy, and I'm not going to be talking about therapeutic applications. Just what has happened here at the University of Minnesota. And the area I'm going to be talking about is located pretty much right in the center of the brain. And so this is just a parasagittal section from a cadaver to remind us of the anatomy. The pituitary, even though it's deeply located, can be accessed through the sinuses. And it's surrounded by the sphenoid bone. And it's more easily diagrammatically, the pituitary gland is right in the center of the diagram here in the yellow. And this I'll be referring to as the intrasellar space. It's also known as the sella turcica, and it's bounded inferiorly the sphenoid bone, and all of that region I'll just refer to as infrasellar. There's an invagination, a partial septum of the meninges called the diaphragm sellae, through which the infundibulum passes, and that joins to the optic chiasm as well as the hypothalamus, and all of that suprasellar. I'll just treat that all as one area. And then laterally is the cavernous sinuses, one on each side. And so what I did here at the University of Minnesota is actually Sammy Amarush did the actual search for it, but we did a natural language search of the COPATH database going back to about 2002 and searched both for anatomic terms as well as diagnoses that are specific to this area. And over those 14 years, I came up with about 335 different cases. And so that's the baseline of what the presentation covers. And the distribution of those cases is, you can see by far and away, the most common lesion is actually the intrasellar compartment. There are much fewer in the sphenoid sinus, as well as above the cella in the suprasellar region. And then, kind of as to be expected, the cavernous sinus being filled with blood, surgeons are adverse to getting biopsies and manipulating that unless they absolutely have to. So we only have a couple of examples of biopsies from the cavernous sinuses. So focusing on, I apologize, I'm just hitting the wrong button. So the intrasellar differential diagnosis, if you open up Ellison and Love's neuropathology text, they list these 4 different entities as pretty common diagnoses that can be found in the intrasellar region. And so, as you can pretty much all guess in your mind what the most common diagnoses here at the University of Minnesota is, but you're going to see something like this, especially at frozen section, a monotonous population of cells with kind of cytologically bland nuclei, maybe in an organoid pattern. It may or may not have necrosis. And so in your mind at this point, with that description, you should be thinking, oh, that's the reference for this picture, without giving away the diagnosis. This is a pituitary adenoma. And so out of those 308 cases in the Sellar region, 276 of them are pituitary adenomas. So by far and away, almost 90% of Sellar lesions are going to be pituitary adenomas. And they're roughly broken down equally among genders. There's a slight female predominance, but again, it's a relatively small series. The age of onset is, or at diagnosis, I should say, is in the 50s, both for men and women. And there's a similar age range for both men and women. And the WHO makes a point that pituitary adenomas are actually quite rare in the pediatric population. In some of the published incidents, only about 2% of Sellar tumors occur in the pediatric population. Will be adenomas. And so maybe a couple of the females, the pre-adolescent females, would qualify for a pituitary adenoma. But again, that's less than 2%, which is consistent with the reported literature. So pituitary adenomas, they naturally produce these 6 hormones like we all learned in medical school. And there's a lot of variability in the extent to how a pituitary is worked up at different institutions. Some places will just say pituitary adenoma and stop the work up there. Others will pursue tumor expression with immunohistochemistry. And then there are some institutions that will even go to electron microscopy to look for some of these sparsely granulated variants. And there is some small survival difference with a few of these variants, but by and large, the prognosis is the same for most pituitary adenomas in that they are a benign neoplasm. They can recur locally and require additional surgery, but in general, they do not metastasize. And so here at the University of Minnesota, out of 288 pituitary adenomas, 14 of them, or about 5%, were evaluated for one of these 6, at least one of these 6 hormones to see if it was potentially a functional adenoma, which leads me into the ways that adenomas present. Roughly speaking, you can have ones that produce the hormone and produce clinical symptoms, and they tend to be very small. In fact, so small sometimes we don't detect them in a pathologic sample. Or the opposite is if the adenoma, even though it may produce these hormones, it doesn't secrete them into the body, or they're non-functional. And these adenomas tend to grow very large and produce mass-like symptoms in the brain. And so this is just a diagram I got off the internet. And so with this constellation of features, this is what you would see with a person with Cushing's syndrome. And that leads me into, as far as microadenomas, there's 2 in particular that are very frequently associated with functioning microadenomas, and the ACTH producing microadenomas are one of those. The other one that comes to clinical attention as a microadenoma occurs in women, and that's prolactinomas, because women who start lactating without being pregnant want to know why, and so they come to medical attention. Other adenomas can also secrete hormones. You can get gigantism or acromegaly depending on your age if your pituitary adenoma secretes growth hormone. But it's more variable with the other hormones other than ACTH and prolactin. And when those pituitary tumors become large, you can get something like this. You can look at the top one is what most of everyone sees is a full panorama of the building, the art museum here on campus. But if you're pointing out the building, the Moose Tower, which is on the right side, and they say there's no building, all I see is the art museum. People with bitemporal hemianopsia due to compression of the optic chiasm will have this symptom. And so they lose their peripheral vision. And so pituitary adenomas can present this way. They can also present more non-specifically with like headache, nausea, and vomiting. Radiologically, there's several different classifications for pituitary lesions. I just show this to make the point that pituitary, or I should say sellar neoplasms aren't always confined to the sella. And in fact, they can erode up through and involve the suprasellar region. They can destroy bone and extend into the sphenoid bone or the sinus below. And they can also erode laterally into the cavernous sinuses. And so in our series of sellar tumors, 14 of the prolactinomas actually were mainly involving the sellar region, but did erode down into the sphenoid sinus. And then the two examples of cavernous sinus biopsies were also pituitary adenomas that had grown laterally. And I thought it was interesting that here at UMMC, there were no pituitaries that extended from the sella itself superiorly into the suprasellar area. There were pituitary adenomas can be found in all three compartments. Because of development, pituitary arrests are relatively common along the midline. And so isolated suprasellar and infrasellar adenomas can occur. And here at UMMC, we did have isolated suprasellar pituitary adenomas, but again, none that bridge between the suprasellar compartment and the sella itself. The pituitary gland is, the vascular supply of the pituitary gland is somewhat unique in the body in that the adenohypophysis, or the anterior pituitary, has a portal venous system. The neurons that control the secretion of the hormones of the adenohypophysis go through this portal system, and that's how the body has developed to communicate between the CNS and the endocrine portion of the pituitary gland. But since it is a portal venous system, it's also exquisitely susceptible to hypotension and infarct. Whereas the neurohypophysis, or the posterior pituitary, has its own arterial supply and is less susceptible to infarction. And so within the experience here at the University of Minnesota, out of the 288 pituitary adenomas, about 8% of them showed infarction and tumor necrosis. I should say 8% showed some focus, whether it was just a microscopic focus or it could be complete infarction that you can see in like pituitary apoplexy. But necrosis is often associated with malignancy in other organ sites, but that is not so with pituitary adenomas. And again, that's a consequence of the portal venous system. And just broke down the cases of infarction. It seems to be equally distributed between men and women, and a pretty broad age range in both genders. Another feature of malignancy that we see in other organs that doesn't quite apply to pituitary adenomas is recurrence at the site. many times if a tumor is excised and then recur, that's a sign of malignancy. But the pituitary, because of its central location, it's very difficult for neurosurgeons to completely excise these neoplasms. And so, again, at UMMC, almost 4% of the pituitary's neoplasms had at least a prior history of a pituitary adenoma. And again, this is not an indication of malignancy. It's more that it's just difficult to reach. And there is an entity, pituitary carcinoma. Histologically, there's no way to make the distinction prospectively in a reliable manner between what looks like an adenoma and what is a carcinoma. And the only feature, the one feature that's needed to diagnose a pituitary carcinoma is metastasis somewhere outside the body. And there were no examples of pituitary carcinomas within this data set. So that's the largest portion of the Sellar tumors. This is the Bohemian Flats this last weekend. So just a little greenery showing off the colors. So getting back to the differential diagnosis, in your minds, think of these remaining three and which one do you think is most likely in our data set. And this picture, you can see an epithelial layer. It seems to be stratified a little bit in areas. You can get a hint of some ciliated cells. There can be mucinous cells in some examples. But this is Rathke's cleft cyst. And this is the second most common neoplasm encountered in the cella here at the University of Minnesota. And that's the reference. So, going from roughly 280 cases of pituitary adenomas, we take a huge, like orders of magnitude cut to the second most common intrasellar lesion, and that's the Rathke's cleft cyst. And in the 14 years, there's 8 cases that were restricted to the cella. They were equally divided between men and women, and again, because of the small numbers, I've just listed the age range, the individual ages, and they seem to be no obvious difference. But Rathke's cleft cysts aren't restricted to just the Sellar region, and in our data set there was also 2 that were suprasellar. And again, there was 1 man and 1 woman, a young man, but we're dealing with individual cases here, so there's no way to really infer to the population. So Rathke's cleft cyst, there was a total of 10 cases in our data set. Another lesion, cross that off the list. So now we're down to in your mind, what do you think would be the next most common lesion going forward? And so if something crosses your microscope that has this appearance, basaloid neoplasm, it seems like this particular neoplasm, the basophilic material inside the lumen of this cribiform architecture never projects well. But there should be basophilic basement membrane-like material there. Very characteristic. And then adenoid cystic, that's the reference. So there was 1 case of metastatic adenoid cystic carcinoma. And then there was another person that had this hepatoid appearance when they did the pituitary biopsy. And so we also had 1 person with metastatic hepatocellular carcinoma. I say 3 cases because the young man who had adenoid cystic carcinoma actually had to have surgery twice. And so he counted for 2 cases, but there was only 2 patients. And no women had metastatic disease, again, in the experience here. So that leaves us with the granular cell tumor. And so granular cell tumor in the Sellar region looks like granular cell tumors elsewhere in the body. They have granular eosinophilic cytoplasm that's PAS positive. And again, from the internet, this is supposed to be an actual pituitary granular cell tumor. But at the UNM, there was no cases in the surgical pathology files of granular cell tumors. However, they're here. They're just in a different series, and it's probably the autopsy series. There's such thing as a granular cell tumorlets that don't come to clinical attention, and in some autopsy series, if you carefully look at the pituitary and the stalk of the pituitary, you can see granular cell tumorlets in up to 25% of people. So the tumorlets are there. Granular cell tumors that come to clinical attention because of mass effect are quite rare, and there are no cases here at the University of Minnesota. So, for those of you who are keeping track, you know that I've not accounted for everything. For everyone else, I've supplied the numbers here. Again, the intracellular cases of lesions, I said there was 308. I mentioned there was 288 adenomas earlier. That included from suprasellar, intrasellar, and infrasellar adenomas. But those pituitary adenomas located at least partially in the intrasellar region, there was only 276 of them. There was a total of 8 Rathke's cleft 6 and the 3 metastatic cases from 2 patients. So I now have 21 different cases that the reference text hasn't captured. So as you're thinking through your differential, you might think of something like this. This neoplasm is classically described as having a stellate reticulum. That's the looser areas with the clear spaces. It also described as a biphasic tumor. It'll have a more highly cellular area with a characteristic peripheral palisading of the tumor cells. And then in the textbooks, when you hear of wet keratin, they're talking about this appearance of keratin where you can tell it's squamous origin, but the nuclei are completely absent, or all you see is the ghost-like lacunae. So this would be wet keratin. And this is an Adenomas craniopharyngioma. There's also this type of craniopharyngioma, which has more of just a squamous appearance, lacks the wet keratin and the stellate reticulum. And so this variant is called a papillary craniopharyngioma. And so here at the medical center, there was 5 cases of intrasellar craniopharyngiomas. And from the search, I couldn't tease out which of the 2 types these were. But they seem to occur about equally in the genders. I've given the age range, all the way from the very young to, mature adults. But again, small numbers. It's hard to know, get an exact population distribution. And kind of as before, craniopharyngiomas aren't restricted to intrasellar cases. There are 2 cases of suprasellar craniopharyngiomas in our data set, which is kind of at odds with what's been published, because craniopharyngiomas are typically described as a suprasellar lesion. They are known to occur within the cella, but that's usually the smaller population. So here at the University of Minnesota, I'm not quite sure why, but we seem to have more craniopharyngiomas within the cella itself. So that takes care of 5 of 21. So we're getting down to more and more rare entities. And so this lesion has a pretty characteristic appearance, usually described as whorled and epithelioid. And although this picture doesn't include it, there's very often nuclear pseudo-inclusions. And so this is the very typical appearance of a meningioma. There were 2 cases of intrasellar meningiomas because the dura does line the cavity of the cella as well as form the diaphragm cella through which the stock passes. But since it's a small area, meningiomas in this area are relatively rare. And as you can see, we had 1 man and 1 woman. This lesion can be found anywhere in the body. And so it's squamous epithelium that's keratinizing. The keratin you see is not going to be described as wet keratin, it will be woven keratin. You also see a granular layer. And so this, without any other history, I also need to mention that there's no adnexa, so this is not skin. It's strictly keratinizing squamous epithelium. And so this is an epidermoid cyst. Again, they can occur elsewhere in the body. We had 1 case that occurred within the cella in a 53-year-old woman. This picture you're seeing, you can see islands of the Adenohypophysis, and then the small blue cells sprinkled in between are lymphocytes. And so even though there's mass-like lesions, it doesn't have to be a neoplasm. And sometimes hypophysitis can trick the radiologists and the neurosurgeons and appear to be a mass within the cella, but it's actually just inflammation. And there can be lymphocytic hypophysitis, granulomatous hypophysitis. So it just depends, the specific subtype of hypophysitis depends on the cells that are present histologically. But there were 3 cases. And I just point out, it seems like this is present in a younger population. Even though we just have 3 cases, it seems to be younger people. And we'll let you know that one of these cases of hypophysitis was actually associated with a ruptured craniopharyngioma. So the reactive and tumors are not mutually exclusive. You can sometimes see both pictures in one biopsy. So I've lost track. I think we're down to about 10 or 11 unexplained cases now. And so when you're sitting at the frozen scope and you see this sort of picture, again, epithelioid cells, some are pink, some are blue, they're all cytologically bland, some are granulated, some are not. It's just a mixture of different cell populations. This should make you think of normal pituitary. And so I include this because not every exploration for a pituitary tumor comes away with a pathologic diagnosis. But, and as you can see here, about 3% of the time, so it's a very low, overall it's a very low proportion of times where we cannot give a pathologic diagnosis. But if you remember how some of these lesions present, especially the functional prolactinomas can be microadenomas. Cushing's disease, which is caused by an ACTH secreting pituitary tumor, can be very small. And the way the surgeries are performed, they have to constantly suction because of the vascular nature of the pituitary. Sometimes the neurosurgeons can accidentally suck the lesion, the adenoma, away with the blood that they're trying to control in their surgical field. So this requires a little bit of context to say that they've sampled normal pituitary, and just realize that what we had available for pathologic examination wasn't able to substantiate what was probably a microadenoma. And you can see that in the female predominance with this finding, about 9 times more likely. And again, women who present with lactation are one of the more common presenting presentations for microadenoma. So I believe that's why they are overrepresented with this diagnosis. So this is a summary of the experience here at the University of Minnesota, and you can see the next time you have a pituitary lesion that you're asked to do a frozen section on, the vast majority of intrasellar lesions turn out to be a pituitary adenoma. And in the series here at the medical center, about 90%, so an overwhelming majority. But there are enough other additional entities out there to keep you on your toes. Again, they're orders of magnitude less common, but the Rathke's cleft cysts and the craniopharyngioma are the two that you need to think about, keep in your differential diagnosis. They also have characteristic histologic appearances. And then after that, you get down into the much more rarer entities, which you will probably recognize if, especially metastasis, that the patient has a primary diagnosis elsewhere. And so, I want to thank specifically Sami Amarouche for helping me with the search of the COPATH database, which without his help this talk wouldn't have been possible, but also all the pathologists here at the University of Minnesota, particularly the neuropathologists, as well as the patients who over these 14 years have chosen to have their surgeries here at the medical center. So at this point, I would like to open it up for questions. Yes?
I have several comments. I'm not quite sure how the search was done for cranium. That is drastically underrepresented in the scene. I would say we see at least a couple of years, we probably have 30 to 50 craniums we've seen during that period. Also, the Rathke's cleft cysts may be underrepresented just because of how they are encountered. The surgeon goes in, they get to the lesion, they pop it, and all the fluid runs out, and they don't even give you a sample, or if they do, it's normal pituitary. So some of those normal pituitary cases may be examples of Rathke's cleft cysts. So you don't always get the wall of the cyst as a certain specimen. So I think we probably encounter greater numbers of those as well, but they don't necessarily get a pathological diagnosis because either no tissue is submitted or what's submitted is not diagnostic of the cyst.
Right. Yes.
Thank you, Matt, for the presentation. This was really impressive, and several aspects of this series are impressive. I think the one thing that this series the one thing that this series reflects is the consistency, because this is managed by one of the world leaders, the neuropathologist. He has been doing this consistently in the same way through the years, so it is very unique. You will not find many series that are so complete and so well structured like this one. So probably there is a good opportunity here to pursue this further and try to answer some questions. You kind of alluded to how to use the information here for the general surgical pathologist out in the community when if they have a neurosurgeon and they are faced with some challenges intraoperatively. So maybe we want to pursue this series even further to look at the scenarios of the intraoperative. Because I would imagine probably, Brent, you did a frozen section of every single one of them.
Oh, I tried to discourage that. But
I'm sure you did.
But actually, just sort of a tip on frozen is that touch preparations are extremely valuable because tumors have no particular boundary and they'll touch off repeatedly. So you can just continue to touch and every touch will look the same. Whereas normal gland you might get a few cells on your first touch and then it basically disappears. So that can be actually almost like a litmus test for sometimes more valuable than trying to convert it to architecture in a trial section. I'm not a big cytology guy, but that's
That's okay. Cytology is good also. So several analyses can be deducted from here. For example, the ones that were performed by Dr. Clark and the ones that were performed by other surgical pathologists when he's away, what happens during regular hours when consultation is available versus after hours when the surgical pathologist is stuck with a case in the middle of the night. That sort of thing, it's a very nice series, and it is quite similar to what we see in most academic centers. As I say, the uniqueness here comes from the consistency being done by the one neuropathologist.
And I agree, the data I summarized for you is based on the final diagnosis. I thought it would be interesting to go in, because many of these cases have 1 or 2 or 3 frozens, and I agree it would be interesting to go into the intraoperative consultation portion of this, but I ran out of time. Yes?
Pat, could you expand a little bit on the indications for carrying the work up further through immunohistochemistry to determine which of the hormones are produced? You alluded to the fact that very few are actually carried that far. What is the indication for doing it?
Well, there is no medical standard for the evaluation of a pituitary adenoma. I believe probably the largest driver is what the clinicians will do with the information. So I don't know what the preference here is among the oncology staff at the University of Minnesota. I suspect that most of the adenomas that had immunohistochemistry performed on them here were for microadenomas, just supportive information for what they were seeing clinically, whatever syndrome they presented with. Beyond that driver, it's the antibodies are available. Unfortunately, even this was over 14 years, and so 288 cases over maybe 20 a year, 1 or 2 a month. The antibodies, it's really hard to justify keeping the antibodies around for that level of usage because they outdate.
I think back in the 90s we did back in all of them, and nobody really cared.
Okay.
And so we stopped doing it. And then they stopped buying antibodies, so we really stopped doing it. So occasionally we do them as Matt's indicated for microadenomas or something. You're looking for ACT cells. Once in a while, an endocrinologist will ask us to do it for reasons I don't quite understand. Because if the tumor's endocrinologically active, they can follow that. If it's not endocrinologically active, they can't follow it, regardless of what the immunohistochemistry shows. So it really isn't particularly clinically valuable to know the immunophenotype if it's not circulating hormone. But so I mean, In the past, we actually worked in it much more, but like I say, we seem to go care, so we decided why spend all that money on that.
Yes.
Sorry. Did you look at the endocrine production of these tumors, the adenomas?
I did not. No. That's another area that I could have explored, and I think it would be interesting to know what the clinical presentation of each patient was and correlate that with the pathologic findings. But it's possible to do that, but I did not at this point.
Thank you.
Okay, thank you.